Well, welcome everyone. My name is Christine Sellinger, and I work with the Alberta Sport Unit in the Capacity Development Platform. And before we get started, I would like to acknowledge that although we're meeting virtually, each of us live on the traditional lands of First Nation, Métis, and Inuit people, whose histories, languages, and cultures continue to influence and enrich our vibrant community. I'm pleased to welcome you today to this session on Canadian Health Advanced by Nutrition and Graded Exercise Trial, or CHANGE trial. But before we get started, just a few things for housekeeping. This session is best viewed in speaker view, not gallery view. Please keep your video camera off to ensure privacy and to prevent interference with your audio. To access reaction buttons, such as a thumbs up, click on participants at the bottom of the live stream window. You will then see the reaction icons at the bottom of the participants tab. If you have questions, please post them in the session Q&A box or the chat box in Whova, not in Zoom. We have Donna Presick from our team here to help moderate questions. If you experience technical difficulties, the best first step is to exit and then rejoin the session. You can also post questions in the chat box in Whova for technical help from our team. This session is being recorded, and you can watch the recording later when it gets posted to Whova. So, our speakers today are Dr. Doug Klein, an associate professor with the Department of Family Medicine at the University of Alberta and director of Change Alberta Research Group. His research focus is on healthy eating and physical activity, both in the clinical setting and in the community. And Dr. Klein is a recognized expert on lifestyle intervention in primary care. Dr. Amanda Verdill is an evaluation lead in the Department of Family Medicine at the University of Alberta. She holds a PhD in school and clinical psychology, and her research interests focus on motivation and emotion in learning environments, along with interventions that help folks live healthier lives. Okay, let's get started. Dr. Klein, take it away.
Great. Thank you very much for having us, and thank you for all tuning in. It's really great to be able to still present. I know that this is a different format than the typical SPOR Summer Institute, and but we adapt, and we are still able to share some of our knowledge and connect with the research community despite some of the challenges. So. Yeah, is that Amanda and I are really thrilled to be here, and hope we'll be able to tell you a little bit about the work that we're doing, as well as have some opportunity for questions from the group as well. So let's get started. Most of our work, Amanda, next slide, please. So most of our work is around the, this is just, you can move on to the next slide. So most of our work is related to this concept called metabolic syndrome. And this is a term that we sometimes don't actually use out in the community or in practice, but it's made up of a whole bunch of things that we know a lot about: blood pressure issues, diabetes or sugar issues, cholesterol issues, and problems with weight or waist circumference. And so I just highlight this is that the metabolic syndrome is when 3 or more of these 5 conditions is present. And I'd like to highlight one thing is that you'll notice on the right-hand side is that you can meet the criteria by having an abnormal value or actually receiving medication for that condition. So your blood pressure might be normal, but you're taking blood pressure medication for it. You would still actually meet that criteria of the metabolic syndrome. So next slide. Metabolic syndrome is really common in the population. It's almost 20% of adults have this condition. And as we go into sort of the older demographics of our population in Canada, the rate increases to almost 40%. So this is really, really common in Canada. Next slide. So what is CHANGE? So CHANGE, as you is actually an acronym. It's actually Canadian Health Advanced by Nutrition and Graded Exercise. And this is a program that was developed back in 2011. There's actually 5 universities in Canada came together and looked at all the evidence around diet and exercise and came up with a program that would use that sort of a team-based model, and using the evidence, using the science that we know around behavior change to implement a program that would fit for primary care. And so this program was designed for primary care. And in this program, it certainly, the family doctor plays a key role, particularly in some of the identification and motivating of patients. But a lot of the work is actually done by the team members. So the dietitian, the exercise specialist are doing a lot of the work for as part of this program. So next slide. So this is just an overview of the program. It's a one-year program. And in the first sort of 3 months, so you'll see sort of 1, 2, 3 on that curvy line, that's where a lot of the work is actually done. So the family doctor will see the patient initially, but then the dietitian, the exercise specialist will see the patient weekly over these first 3 months, and working on setting goals and developing some new habits around both physical activity and healthy eating. For the remaining 9 months, so on the 4 through 12 on this diagram, is the dietitian and the exercise specialist meet with the patient monthly to continue along and support the patient, but eventually building some confidence that the patient can then actually do things on their own. And so that's the overview. Next slide, please. So what is so different? Certainly is that I always say is that I do the work I do is very novel, and but certainly diet and exercise is something that has been around for a long time. But we actually haven't found good ways of actually making and supporting our population in making these lifestyle changes. And so these are some of the reasons why the change program is different. So one is that it's actually embedded into primary care. So the family doctor is your family doctor who you've got a relationship with. It's personalized. So like if the whole group of us on this call were part of the program, we would all have a slightly different personalized diet and exercise plan. It uses the team. So using that exercise specialist and the dietitian, rather than actually, often people do come to me to about advice around diet and exercise, but actually my training in sort of nutrition and physical activity is actually quite limited in medical school. And so we want to use those team members who actually have more training in what actually works and how to help people. And it's a gradual intervention, so setting goals that are achievable and then gradually progressing up. And as I mentioned, it's a 12-month intervention, which we know that a longer intervention actually is needed for habit generation and new habit formation. Most of us sort of feel that you could do anything for a month or so or 6 weeks and it's easy to fall back into your own habits. But if you extend and do something for a longer period of time, it's more likely to stick. So next slide. So the next 2 slides actually are just some of the topics that we end up working with patients on during the change program. So you'll see sort of a range of sort of balanced meals, cooking skills, nutrition literacy. And if you go to the next slide around physical activity, is that learning about sort of perceived exertion, intensity, reducing sedentary time, and sleep being an important piece of the physical activity, our physical activity health as well. So next slide. So this goes back a little while, but I wanted to give you guys the where some of the history of this change program. So here's three of the universities that were involved in the original demonstration project. And so we were in primary care settings across Canada, and we looked at the metabolic syndrome variables. In addition to this, there was some genetic analysis, which I'm not going to touch on right now, but certainly happy to answer some questions about that and after the presentation is done. Next slide. So what we found is that over that demonstration project is about 20% of people actually reversed their metabolic syndrome. And so if you go back to that definition of sort of either having like an abnormal lab value or abnormal blood pressure, or taking medication, reversal of those conditions actually required you to not only that your sugars return to normal, but you were not on any medication to do that. And so when we think of like 20% of people have actually returned their values to normal without medication is quite a significant amount. And then on the right-hand side would be people who ended up improving a couple of those conditions, but they may still actually have the metabolic syndrome. So they still meet 3 of 5 criteria, but they actually improved 1 or 2 of the conditions that make up the syndrome. And just to compare is that like in sort of 20 years of practice, I would say that the number of people who have metabolic syndrome that would have reversed it, so that they were started on either medication for their diabetes or their blood pressure, and that they got off all of that, was like really, really low. Like probably in 20 years that I encountered, I think maybe 1 or 2 people that ever actually did that. So this 20% is actually quite a significant change from the natural history of the condition. So next slide. This just shows that it affected all of those conditions that were on that sort of first page. And next slide. And in addition to sort of changing those lab values, one of the things we think about is actually that cardiovascular risk being a key finding, and so we were able to decrease the cardiac risk in the population that we had in that project. And then on the next slide is actually what I feel is probably one of the biggest successes of this project is actually looking at sort of the confidence, because what I think is lacking in a lot of people is that they know that they may need to be eating better or doing more physical activity, is that they know what they need to do, but they're not very confident in their ability to do it. And so the fact that at the end of this project is that like most of the patients that went through this program were sort of were very confident or moderately confident that they would continue those changes that they started during the project is a huge success. Next slide. So Amanda's going to go through some of the current trial, and then we'll talk about some of our lessons learned and some of the takeaways from our work at the University of Alberta.
Mm-hmm. So hi everybody. So I'm going to talk about the current trial, which is Change Cancer Alberta. And so what it is there's really 3 parts to the work that we're doing now. There's a cluster randomized control trial in 16 PCNs across Alberta, which is a really large scale trial of the Change program, with multiple clinics involved across most PCNs, and then a lot of family physicians that are actually involved with the work that we're doing. In addition to the RCT, we also have a cost effectiveness evaluation that's being done to examine healthcare savings in in a couple of areas, chief among them pharmaceuticals and then healthcare utilization rates. And then finally, we have a qualitative portion that's looking at what are health professional and patient experiences of the intervention. So what are the things that they enjoy? What are the things that they, what different challenges have they identified with the intervention? So just to kind of give you a little bit more around the cost effectiveness evaluation, we're working on that with Dr. Chris McCabe at the Institute of Health Economics. And the idea is that in terms of pharmaceuticals, there could actually be a fairly significant savings if the change program is implemented across PCNs. And then we would also expect to see reduced acute care health utilization rates because with reduced risk of kind of these major health events like Doug was talking about earlier, you would see less emergency room visits required and different visits of that nature. So this is still in progress. So then when we look at the timeline, you can see that originally for the RCT, there was a 4-year timeline. And so I'll tell you that we started this work in 2015, which means that we should have been completed in 2019. But here we are in 2020 doing this presentation and saying, we're still continuing to work on it. So clearly this work has gone on a little bit longer than planned. And we'll talk about some of our lessons learned later on, as Doug mentioned. And I just want to say that it's really important to note that the trial has to continue for 18 months after recruitment into the trial is actually complete because of the length of the change program, which is a year. And then we're also doing a 6-month follow-up with patients to see if some of that, has the change stuck idea. So we are working with sites across Alberta. We have 8 intervention sites, 8 control sites, looking at them in terms of do we have urban sites? Are there rural sites? Because perhaps there are certain characteristics of different PCNs that make it a bit easier to offer the change program and others that make it a little bit more difficult. There have been some changes to sites as we've been working with them, kind of in terms of, PCN staff or just generally how, where do different clinics fit into PCNs? And again, we'll talk a little bit about that in some of the lessons that we've learned. Here I'm showing you our recruitment progress. You can see that 2018 was a great year in terms of recruitment for the RCT. Our goal initially was 800 participants, so 50 participants per PCN. Currently, we have 648 participants. And so we've revised our goal in talking with our stats folks. We'll still have enough power to look at the effects that we're hoping to find with 750 participants. So just decreasing that a little bit. You'll notice that our numbers for 2019 were a little bit lower than what we would have liked to see. Some of that has to do with staff changeover on our research end, some PCN staff changeover. And then 2020, we'd gotten back into things. Everybody was trained and off we were going. And then bam, March 2020, we had our lovely coronavirus pandemic, which slowed our recruitment as everything kind of was closed down. But it was also, a bit of a challenge that our team rose to, and we were able to talk about, well, how can we do some of this remotely? So we were able to start doing some remote screening, really to respond to the needs of patients. So now I'm going to talk a little bit about, what are some of the health professional perspectives? What have they identified as, what are some of the program successes? What are some of the program challenges? And so to just give everybody a little bit of background, the qualitative work that we're doing is both inductive and deductive because of some of the questions that our funders are interested in knowing. So we asked general questions and then coded based on a general inductive thematic analysis with 2 coders. But we also asked specifically about pulses and pulse use, because one of our funders was interested in, how do folks use things like lentils and chickpeas and different things like that in their diets. So our general kind of large themes that came up were that health professionals talked about program successes, a lot around building relationships. That one of the program successes is that individualized plan, like Dr. Klein mentioned, where patients really come in and they have a plan that's meant for them. That there was increased knowledge, and even it was a gateway to additional services. So we had a couple of folks who talked about how they learned a lot about their sleep, and a few folks even ended up with CPAP machines because of being involved with the change program. There were also lots of things about measurable changes. Health professionals saw these changes in patients as they were working with them. There were some program challenges that they identified. Health professionals were wondering about, were participants really ready for change? Was the structure of the intervention where they saw, where health professionals saw patients weekly and then it went to monthly, was that, were there any things that could have helped to keep that relationship between the health professional and the patient going a little bit more closely? And then one of the challenges noted was a rural setting in terms of, the length of time it would take patients to get to the actual PCN where they were doing the intervention. What was really lovely is health professionals all also talked about solutions for some of the challenges that they saw. Things like, working more collaboratively together, maybe considering self-referral, assessing that readiness for change, that they all saw that these were things that would really help the program. And then in terms of pulses, folks struggled to add it to their diet, but they did find that a stepped approach would work. And folks really did increase their knowledge around, pulses and how to use pulses in their daily lives. So that's health professional perspectives. And then there's also patient perspectives. And so patients talked about, the same kinds of program successes. They really talked a lot about re-engaging in life and feeling like through the change program, they were able to do things that they hadn't been able to do before. They again talked about, this being a gateway to other services and realizing that these services were available in their PCNs. In terms of program barriers, there were things, that came up like life responsibilities, staff turnover, which makes sense when you think about the importance of relationships that health professionals identified, and that, patients also identified. Patients identified that, being able to work on their own plan with setting their own goals was something that was really empowering for them. And it was also lovely to see that there were solutions for some of the barriers that patients did identify. Patients talked about having their families involved, increasing staff availability. So thinking about the hours that staff are available to patients, typically a PCN would be 9 to 5. Could that be extended to, would somebody be able to meet at 7 o'clock or something like that? And then patients also wanted, more homework, so more work to do, and then to lengthen the program, so to keep having the program in their lives. In terms of pulses, we had a lot of folks talk about, like I incorporated it into my diet. We had there was one patient who called herself kind of the pulse queen, and she was going around and telling everybody, you got to make these brownies because they taste super good. But that's kind of some of the stuff that happened there. There were also folks who talked about having an intolerance to pulses and not being able to incorporate them into their diet as much as they wanted. But they did also talk about really enjoying this new portion for this new thing for them. So these are all sample codes from the interviews that we did. But I think that you can kind of see overall, folks, health professionals and patients both seem to enjoy the change program. And while they did identify barriers to being able to fully participate or engage with the program, they were also quite happy to provide solutions for those barriers. We are continuing, so this research is ongoing. We expect to have kind of a full, a fulsome picture probably somewhere in the next 2 years, because we're recruiting up to the end of December of this year. And then we'll need to have an 18-month follow-up and, time to do all the research magic, and then have a final report coming out of that. So I will turn this back over to Doug, and Doug will talk about some of our key learnings from the trial thus far. Doug, you're muted.
So if you move to the next slide, would be great. So Amanda did talk about relationships, and I would say that certainly relationships between in the program, we often sort of think that's between the healthcare team and the patient. And certainly that was there, like certainly is that the family doctor and knowing that this individual may have had either sort of a family member who got sick, or maybe it's a new grandchild. Those types of leverage points were really important in sort of being able to motivate people to be involved. And certainly the dietitians and the exercise specialists involved use those relationships and those things to help motivate behavior change. But I also feel that from a research perspective, is the relationships were really important. And so initially, I actually spent some of my time working in continuing medical education, and so working with docs and from around the province and in different primary care networks, and it's some of those relationships and being able to sort of reach out and talk to people and realize that, oh, well, is that that things may not be a good time to participate in a trial, and despite my encouraging them to want to participate, is that it might not be a good time with their PCN or in their environment at that time. And those relationships were really important, because when you think of a trial that lasts for 4 or 5 years, is that you actually need to invest in those relationships between your research partners, whether it's the PCNs, whether it's the docs in the community, whether it's the dietitians across the province, the exercise specialists across the province. Those relationships are the pieces that will keep that project being successful long term. And we've actually, because the trial has gone on for a long time, there's actually PCNs that initially when I approached them, they were like, no, I'm sorry, we can't participate right now. And then they're actually reaching out to us and saying, is that, hey, we're actually, now we're ready, we're interested. Is there a way that we can be involved in your trial still? And so those relationships were really, really key. The second thing was the persistence on being persistent on funding, right? Is we initially applied to CHR. We were successful in getting small amounts from CHR, but going and talking with all sorts of different people. So is that, and that's partly why this project is there's actually cancer in the trial name, is that what we know is that the risk factors for cancer and the risk factors for heart disease have a common thread around diet and exercise. And so by combining those two sort of themes, we were actually able to put funding together from the Alberta Cancer Prevention Legacy Fund, Pulse Growers, and Metabolic Syndrome Canada, as well as the CHR funding that then gave us enough money that we could actually do the trial the way we wanted to do and ensure its success. Amanda talked about certainly is that getting some feedback from patients and health professionals, and certainly is that definitely I think all of us in this last year have learned a little bit about needing to be flexible and adaptable. And so and we want a program and a system to support our patients that that is sustainable, and so that it fits in the different primary care networks, in the unique things about being in rural Alberta versus in Edmonton or Calgary, right? And so you do need to be listening to those research partners, and being sort of flexible and adaptable, obviously keeping the science and the scientific rigor solid, but you do need to be flexible, and may need to adapt your initial sort of methods around recruitment. Like we went through how we thought we might recruit patients, and then had to actually listen to our PCNs and our partners and say that, oh, well, that's actually not going to work very well. We've got to let's try something different or something else. And so I've got down there having a plan B or a plan C, because I think we're definitely on at least sort of plan C in some of our work here. The other big thing, in particular in research that takes place in the community, is having extra sites being interested and involved. Is that certainly as you're putting the proposal into CIHR, you need to have your sort of 16 sites that were on board, but as time moves on and as we put the funding together, is that things change. And so having extra sites that were interested in the project has really been a key success for our project, because things change, and a site may no longer be able to participate, even though it had an initial intention of joining our project. Next slide. So lots of sort of changeover, and this is probably part of it that I should have known, but I didn't really anticipate, is just the amount of sort of turnover of staff. And like any business, right, is that people change their role. And so we would hire a research coordinator at a particular PCN, and then 6 months later they would move on to a different job, and so then you'd have to retrain and find a new person and retrain them, and those sorts of staff changeovers. And even within our internal research team at the University of Alberta, we had changeover, and so knowing that these projects do take time, and being aware that there is going to be changeover, you're going to need to recruit new staff and retrain them, or train other staff, and know that is part of the just part of doing research. Keeping the project on priority list, like PCNs have a whole slew of different topics and items that they're trying to manage, whether it's sort of women's health, it might be looking at pediatric issues, it might be metabolic syndrome, it might be mental health, it might be addiction, it might be, so is that there's a whole list of things that they're trying to manage. And so keeping your project and on their priority list is certainly something that takes work. And a lot of it comes down to this next item around communication and keeping those relationships and having good communication between your sites, where we sometimes, and certainly is that we admit that at times our communication with some of our sites wasn't as good as it should have been. And sometimes that's actually a result that, oh, well, is actually the recruitment at a particular site was starting to slow down, and you're sort of wondering, oh, well, what's going on? And so getting reconnected and building up that relationship was a key piece in keeping a particular site moving ahead. And then certainly the pandemic has been a huge challenge. It is when you're doing a research trial that requires people to go for blood test result, and the province has said no non-essential blood work needs to be done, is that it can put the brakes on your trial very quickly. And so fortunately we have sort of ended up moving ahead, that patients could go to labs in a safe way and get some of the data that we need to get for our project. Next slide. So I think that the lessons learned, I think we've sort of talked a lot about that. I do want to emphasize patience, like, is that, because it is like, it's a 4-year trial that is sort of now going to be probably about sort of 7 to 8 years, but we've done a lot of really good work. It's just taken longer than what I had thought and what the team had thought at the start. Communication, I talked about. One of the other things that I think when we as researchers, there's so much that we're interested in, is sometimes we try and we want to put everything in, and I really want you who are involved in research to really sort of think about the survey burden for those participants, and so really is that you want to, like, if there's data that needs to be collected or surveys that need to be done, what are the most important questions that you really need to have, as opposed to might be nice to have, and so certainly is that none of this work would not happen without our patients. And as Amanda said, so much, we've learned so much from the patients that have been involved in our project. And so we really need to make sure that and I know that certainly is the idea of having patients involved in projects right from the design stage, and then so that the patients are involved and can be give some input in on, okay, well, what would it be like to fill out these surveys that we feel should be part of our data collection process. The last item is something I've learned more in the last sort of year or two, is, so I'm a family doctor, so about half of my week is actually seeing patients in my clinic, and so my research is done in the other parts of the week. And so having a manager on our team, which we've had over the last sort of 18 months, has made a huge difference for me. One is because I'm not always in the research office, and two is that the managers have these great HR skills that sometimes our clinicians don't actually have, because we're not trained in them. So if your budget does allow, I would highly recommend that you have a manager role on your research team. So next slide. So I actually wanted to, like, we initially were sort of thinking that we might be able to sort of pair people up, but I don't think it's going to work with that. But I just want to give you sort of just 30 seconds or maybe even we'll go to a minute, just to sort of, for you to reflect on the type of work that you're doing, and whether some of the things that we've sort of said have like resonate with your work. Do you feel would be useful in some of the work that you're planning? Yeah, just take a couple minutes, and we'll probably just do about sort of 30 seconds or so to give you some time to think about that. And we can end up getting some of those into the chat, or into the questions that we've got for the group. Would be great. Amanda, do you mind moving to the next slide? We'll just wrapping sort of up. Couple other things around knowledge translation. Certainly publications are a big piece of what how we end up reporting on our research, but they're not necessarily the only way. Is that with social media, we know that information moves differently, and there's around, like, getting information out. Certainly presentations like the one we're doing now is good, but we can also send out information. Like so much information is spread through like Twitter and Instagram and even on Facebook, and so knowing that some of these other channels are ways where we need to actually use to get the word out about the work that we're doing is an important thing to recognize, and also could be used in the recruitment process. And so you want to think broadly when you're looking at sort of designing your project. So next slide, please. So moving forward, currently is that we are doing this randomized control trial in Alberta, but the Change Project is also expanding, and so we've got in BC there are sites in the Pacific Northwest that are implementing change. In Ontario, actually they've received some funding from the Trillium Foundation to roll out the Change Project in sites across Ontario, and also in Quebec, not on this slide, but they are also sort of pursuing rolling out the Change program and in some areas of Quebec as well. Next slide. So one of the other things I just wanted to mention is just to make sure that for you to be open to unanticipated outcomes. So certainly is that through the course of this work is that a whole bunch of different things have sort of come up that I never would have thought. So one is that we actually ended up starting a Change Adventure camp that actually looks at sort of taking some of the work from our research and actually putting it in the hands of children, so that children are actually building those life skills as they become adults, and so that they'll have those skills, and we don't have to teach them when they're say 40 and 50 and they're starting to have issues with their blood pressure and their or their sugars. Looking at sort of building a Change Center of Excellence, and the Change Health Community Program is actually a family-based program that has come out of this work as well. We've got some funding from Alberta Blue Cross to implement some family programming across Alberta, and I think I've talked a lot about partnerships and relationships, and those are key pieces to our success. Next slide. One of the unanticipated was that, so we actually ended up starting a registered charity called Change Health Alberta, and the idea is to be sort of one of the leading health protection and improvement providers for families in the Alberta area. We're looking at supporting families to learn and relearn those healthy life skills, incorporating some of the mental health and social connection, which we know are really, really important, particularly during this pandemic, and partnering with various community members. Next slide. And this is just a little snapshot from the Change Adventure Camp that we've been running over the last few years. If you are interested, you can check out the website and get connected with us. But it's an opportunity to make sure that all children are also growing up with these important life skills. So, next slide. So one is that I want to sort of emphasize, and obviously I'm biased with the area of my work, but lifestyle is important. We know that it impacts a whole range of different medical conditions, and that we can actually help people change their behavior. Relationships are key in research, not only between our participants and our team, but also between our research partners. Research does take time, so be patient, and then watch for those unexpected doors to open in the process of doing your research. Great. um, thank you very much for listening, and I think we've got some time for questions from the group.
We've had a few questions, so I'm just going to voice the questions out loud and hand those over to you guys. The first question was there any discussion with the participants about how change affected their everyday living?
So
go ahead.
So yes, generally folks seem to find that now, because they've done these lifestyle changes, most things were easier. And that they would think about, the example I can give is there was one participant who talked about before they would just watch TV, and that would be it. They'd kind of be the bump on the log, and that's it. But then how it was so easy as they were watching TV on the commercial breaks to get up and to walk around the house, and they didn't realize how much activity and movement they could do doing that while they were still doing kind of some of the same things that they enjoyed. So, differences in diet, differences in activity, and then just generally having more energy and feeling like they could re-engage with things that had been difficult for them before.
And I think that echoing that as well, just like a lot of people, like we try and sort of find what motivates people, and for a lot of them, it might be that they want to be able to keep up with their kids, or that they want to be able to do something, and that was, I think, probably where I see it the most with patients, is that they're able to do some of the things that they felt that they couldn't do before.
Excellent. Okay, the next question is, what is the participation rate of those who are referred to the program? And have you analyzed the barriers to accepting that referral, that is age, family, mental status, or other health concerns?
Yeah, so we haven't done in the original work, is that the participation rate was actually sort of between sort of 80 and 90% of those sort of dietitian, those exercise visits, which I was actually quite surprised with early on, was that it's meeting with somebody every week, which I thought was going to be a lot, but I think that if it becomes if people find it useful, then they're going to commit the time to it. And so we did see very high rates. What we don't probably know, and this is not, I think that in several sort of trials, is that why people don't participate is something that's never really looked at well. We know we can describe the population that consent to participate, but it's sometimes hard to actually capture the reasons sort of why people aren't necessarily participating. I think that a lot of it ends up being time. It's sort of the same reasons for why people are sometimes not doing some of those physical activity things, is that time is a big factor for a lot of people.
Certainly. And that leads kind of into another question on if there was specific selection criteria, or if anyone could go to their doctor and ask to participate.
Yeah, so there was specific criteria. It was quite general, so it was that they needed to, it was adults, they need to have metabolic syndrome. They needed to be able to speak English, because most of our materials were in English. In the earlier work, obviously in Quebec, we had French materials as well. And then there were a few exclusion criteria, which were mainly, one that I'll mention that's quite prominent was that type 1 diabetes was actually an exclusion criteria, because they actually have a different metabolic sort of pattern than our typical type 2s. And then most of the other ones were around safety, is that making sure that it would be safe for them to be able to participate in a physical activity program or a dietary program.
Wonderful. The last question is, what was your process for qualitative data collection?
So what we did is we all of the different intervention sites, we asked if they had, we asked them to send out an invitation to their participants or to their patients to ask if they would be interested in completing an interview with us. And then they would collect that information and let us know who was interested. And then we had a research assistant who completed the interviews with the patients, and then we did 2 coders coded all those interviews after they were transcribed, and then compared across the 2 coders.
And one of the things I know we had sort of, we wanted the PCNs to try and even to pick people who, sometimes you're at risk of only sort of getting input from those people who did well in the project. And so we specifically were sort of asking for the sites to try and actually recruit people who may have struggled during the program as well. And that way we get some of the challenges and that were noted in some of the interviews as well.
Yeah, so the last question, sorry, there was another one while we were answering. If people stopped their participation, were they asked about their experience?
So the short answer is no. And part of that is that we know if they stop their participation, once we get to the end of the trial, we'll be able to look at to see why they've stopped their participation. But we weren't specifically sampling for folks who didn't complete the trial.
From the qualitative piece.
From the qualitative piece, yeah.
We did end up whenever if someone was stopping the trial, is that we did get some, there was some feedback that was obtained, and we've sort of storing that all the way along the trial, just so that we do have some of that information at the end that we can report on as well.
Mm-hmm. And the last one says, is the program done or did it continue?
So the program's still, the research program is still actually running, and then in several on one of the slides that with the timelines that Amanda had shown, is that so the control arms actually end up sort of flipping into, they're actually given some of the training, and so that they actually can offer the program at their site once they are actually done recruiting their control patients. And so we've actually got several sites now that have sort of switched, have finished their participation and are actually rolling out with the program and have sort of integrated that into just their regular PCN services. So yes, it does continue in PCNs across the province.
All right, thanks guys. I think that's all of our questions. So first of all, I just want to thank everyone, including our speakers, Dr. Klein and Dr. Redill, for all of you who attended today. Please continue to post your questions and your comments for this session in Whova, and the recording of this session will be available to watch in Whova within about 24 hours. I'd also like to announce that the Twitter contest for favorite poster and video abstract opens today, so please be sure to vote for your favorite. Winners will be announced after our closing plenary session on November 20th. And this afternoon, please join us in Whova at 2 p.m. to hear about our studentship awardees as they present live on their research projects supported by Alberta SPORE. That's at 2 o'clock today in Whova. Thanks, everyone.
Thanks.
Thanks.